at NYU Langone Health Risk Rehabilitation. My clinical training is in speech pathology. And our RMST program was initially developed within our speech team, but has since expanded and is now collaborative with our physical therapy department. Tonight, I'm going to be discussing the development of our RMST program and reviewing the role of a formalized knowledge translation approach to support develop of our program here. And I just want to mention that this framework can also be modified for developing and initiating any other healthcare initiative that you may want to start within your respective teams and institutions. So just for disclosures, I have limited financial or non-financial disclosures to report, but I do receive a salary from NYU and was provided an honorarium from Aspire for this talk. So for our learning objectives, by the end of this talk, I hope that you'll be familiar with the term knowledge translation and how it applies to the healthcare setting, including the steps needed to design and assess a knowledge translation initiative. From there, we're going to talk through the components of a knowledge translation cycle, providing specific clinical examples from our experiences developing our program here at NYU. So to start, I want to just spend some time introducing the idea of knowledge translation and review some of the potential benefits it can provide when trying to start new initiatives. Okay, so what is this idea of knowledge translation? The term knowledge translation that you'll hear me refer to as KT throughout the talk was initially coined by the Canadian Institute of Health Research. The current working definition was proposed by the National Center for the Dissemination of Disability Research, and it's shown here on the screen. And I promise I won't be reading through a lot of slides. This definition is lengthy, but it sets the background for what we're going to be discussing today. So bear with me for a minute as we sort of read through it together. It reads that the collaborative and systematic review, assessment, identification, aggregation, and practical application of high-quality disability and rehabilitation research by key stakeholders, and this can include consumers, people using the information, researchers, practitioners, and/or policymakers, with the purpose of improving the lives of individuals with disabilities. So for all of us on here tonight on this talk that work in rehab, this is what we're striving to do daily. I'm fortunate to work with an interdisciplinary clinical specialist work group whose goal is to support our program managers with ongoing program development to maintain best practice. Over the last year, our clinical specialist team worked to develop a formalized process to support KT initiatives using a knowledge translation model at our site here at LOH. Tonight, I'm going to share some of our experiences with you in hopes that you can utilize this to facilitate your efforts as well. So KT is a framework that helps to bridge the gap between knowing something and doing and applying it. Educating and sharing knowledge often does not directly result in a change in practice and behaviors. Whether you're responsible for developing initiatives, or you're a practicing clinician who's integrating these initiatives into practice, we know that there are challenges to it being used consistently. I'll give you a personal and somewhat embarrassing example from myself. We recently sort of upgraded our dysphagia outcome measures into our documentation. I was a part of the discussion, was in full support of sort of rolling out these initiatives with our team. And then the first two evaluations I completed after we updated the information, I forgot to enter the data and had to sort of receive some reminders from my boss to sort of go back and edit the documentation. Okay, I think this is just an example of something that happens very often. Even with our best intentions, we sort of need motivation, repeated practice, and encouragement to sort of change the practices that we are performing. Okay, better believe since then, all of my documentation has been 100% accurate and these measures have been included. Okay, the gap between knowing something and doing it has been studied and documented by researchers such as Fisher et al., who found that 30 to 45% of patients were not receiving care according to scientific evidence, and that 20 to 25% of our care provided was not needed, or even more concerning, could be potentially harmful to our patients. These numbers would scare me as a patient. So how can we do better as providers to help serve the populations we're working with? We found that the use of a KT framework assisted us in developing and sort of the success rates of our initiatives that we're bringing to use sort of our new research into practice. When we think about clinical research, the goal is to identify guidelines for best practice that then we can translate directly into patient care. Consistent with Fisher's study, a study by Morris et al. Found an average of about a 17-year gap to successfully translate health research from the literature into practice. The use of a structured KT framework that actively helps to bridge that gap between knowing something and doing it can help ensure that we're providing best practice in a more timely fashion than the research was documenting. Just to give another real-life framework for us to think about, we attend a course and we learn about a new assessment or intervention that we think is beneficial for our patients. Do we come back and are we automatically using it on Monday? There are times that that may be the case, but more often than not, it requires additional training, obtaining equipment, figuring out how to document, standardizing techniques across our teams, okay? And so much more for it to be successful and implemented consistently. The KT process helps us to tackle those challenges. Okay, so this image here depicts the knowledge to action framework that I've been referring to. It was initially introduced by Graham et al., and we have structured our KT program around this model. I'm going to review each component of the cycle and provide specific clinical examples from our experiences developing our RMST program. But just as a general overview before we start, the center of the model shows the need to filter and synthesize information in the literature before it's ready to be used. Or to put it simply, identifying what in the research is salient and has quality evidence to support us using it in our practice. From there, we move to the outer section of the cycle. And this part of the action cycle identifies the phases that are needed to implement information in a way that deliberately causes change. And I just want to point out that there are two-way arrows between all the phases of the cycle. The steps are often thought of to be sequential, but the impact of each phase is bidirectional. And many times we need to pause in the middle of a cycle and circle back to previous steps if we hit obstacles impacting the outcomes of our projects. Okay, so now that we have some background knowledge of what knowledge translation is and some awareness of the potential benefits, let's use the framework to walk through the process of RMST program development that we followed. The initial question at the start of any project is, where do I begin? Clinicians are often coming up with great ideas for initiatives, but they may not know exactly where to start to frame a project to bring it forward to management, or they may not feel empowered to take the lead on an initiative. Since starting this formalized process at NYU, our teams have resources, increased resources and guided worksheets to sort of help them at the initial stages of their project development, framing their clinical questions and sort of initial steps for how to structure their projects. This visual here provides a nice introduction and overview to the workflow that we followed, okay? And I put it here just in case anyone out there is getting bored or hungry already and needs to sign off early for a snack. But to those who are going to hang with us to the end, we'll dive into each of these components a little bit in more detail. Okay, so for any project that we start, we sort of begin by establishing a work group. And this group is going to be responsible for leading the charge in the project. We tend to identify these team members as our champions, and they may have initiated the project idea, or they may be staff showing interest in the project with motivation to participate. We're going to be asking them to take the lead as we go through the steps of the KT cycle, okay, including some of what we have listed here on the slide, completing literature reviews, going for initial training sessions to determine if it's feasible in our setting, helping to establish sort of policies, procedures, and inclusion criteria. Our initial RMST development work group began within our speech therapy team, but we quickly realized that we would benefit from expanding it to include other disciplines. So we then included some of our interdisciplinary team members, and we're fortunate to work in an inpatient setting where we have easy access to include our physicians, physical therapists, and respiratory therapists. And we know that that may be different in different settings across the continuum. Some examples of how we included them in our decision-making. Our physicians were heavily involved in developing our inclusion and exclusion criteria that we'll review later. We worked with our physical therapists as they were developing their program to make sure that our processes were aligning and in alignment with the literature. And then our respiratory therapists were able to help us with some of our initial equipment selection, okay, including sort of giving us advice on manometers and peak cough flow meters, okay, and helping us to establish some of our initial outcome measures that we selected. I'd also be remiss not to mention Aspire here as well as part of our work group, as they became a huge piece of our work group and were incredibly supportive answering our questions as we worked through each step of our process. So going back to link this to the KT cycle, the first phase of the cycle is knowledge creation, and it's arguably the most significant step of any initiative. A KT process often starts when a knowledge gap is identified. Two of the more common reasons a project might be initiated include identifying differences in practice within your team and using this process to help standardize care, okay? And the second one is when new developments or advances are published in the literature that warrant an update of practice. So for us, the literature on RMST was demonstrating the modality was safe and effective for our treated therapy goals, and we wanted to sort of update our practice to include it as a modality. So we began with a clinical question, right? Which patients would RMST benefit in the acute phases of recovery, given that I work in an inpatient acute rehab setting? Once you've identified the clinical question, the first step of this process is an initial knowledge inquiry. And this is where we're identifying all the relevant research available on that topic. From there, we need to take all that information and synthesize it, okay? For topics that have large databases of research, we might be lucky enough to find systematic reviews or meta-analyses summarizing the available results. But if not, it's going to fall on us to sort of evaluate the quality of the studies available. But this is really where we're deciding if there's enough evidence and salience for what we're evaluating to warrant being put into practice. And then the last step of this phase of knowledge creation is knowledge tools and products. And the goal here is to have a concise and well-supported recommendation for best practice. So basically, what are we recommending we do to manage this population or this condition? This can include something like a clinical practice guideline or a clinical pathway when the research is available to support it. So within our work group, we completed a literature review for the populations that we treated most frequently on our unit. And for our unit, that includes stroke, traumatic brain injury, neurodegenerative diseases, and spinal cord injuries, okay, to see what the literature showed. We're very fortunate that RMST has a well-researched literature base across diverse patient populations. There's strong outcomes for safety and efficacy, and they're providing clear treatment protocols for frequency and intensity. And for any of the folks who are calling in tonight who are speech therapists, we know that this is not always something that we find in our literature base. So it was really nice to have the structure as we began sort of developing our program. Okay, so once we have an idea of what the literature states, the second step of the cycle is labeled adapting it to local context. This includes determining the value, usefulness, and appropriateness of that knowledge to your specific setting. Development of research studies often do not mimic clinical populations. They have to have exclusion criteria. Sometimes it's a very homogeneous population that doesn't always align with the patients that we're seeing on our caseloads. So we need to assess if we can mold that information into our setting and our particular populations. Just as an example, at the time that we were developing this project, which was in the pre-COVID era, the research available for use of RMST following acquired brain injury was initiating the use of the modality approximately 11 to 14 days after injury onset. So in our setting, we were thinking, can we adapt that knowledge to safely initiate RMST at an earlier time frame without risking patient safety or effectiveness of the treatment? Another example of how knowledge could be sort of adapted with RMST, our unit sort of transitioned to being a rehabilitative setting for patients with severe debility status post-COVID-19. The rationale for RMST use aligned perfectly with the impairments that we were seeing. So we felt patients could benefit from the modality, but could we train at the same thresholds in patients with severe cardiopulmonary impairments and high O2 supports? Or did we need to sort of make some adaptations to our current practice to be able to sort of treat this patient population safely and effectively? All adaptations we make should be based with sound rationales, making sure that we aren't deviating so far from the data in the literature that we negate the value of the research available. The next step of the cycle is assessing barriers. And this is where we're looking to identify factors that can impact a project's success. We all know changing practice can feel like an uphill battle, whether we're on the project development side or clinicians being asked to incorporate new measures into our practice. Anticipating and identifying these barriers during the project development stage helps problem solve solutions and increase the likelihood of success. It's key to include all members of the team at this phase of the project, okay? Different members from different departments will see things through different lenses and may be able to provide useful insights that you are not seeing from your role on the team. For an example, when we updated our diet systems to align with IDSI standards, we made sure to sort of survey our food service staff, our nurses, and our PCTs, who were going to be the frontline staff, sort of interacting with patients on off hours when speech therapy wasn't here, okay? They were able to provide great insights for ideas of things that we would need to manage and set up before we made the project live. We found that surveys of our staff can often be the quickest way and the most efficient way to get a good number of responses, okay? We'll also sort of insert ourselves into nursing and therapy team huddles when we're able to be able to get feedback from other team members in those formats. When we're thinking about barriers, it kind of helps to organize our thinking by category, okay? Barriers can be present at an individual, organizational, or systematic level. When we're thinking about individual gaps, it may be differences in knowledge, that staff are not familiar with techniques, they don't have the background they need to sort of initiate treatments effectively. Sometimes it can be lack of motivation. Staff are tired, they're burnt out, we have busy days, big caseloads, which sort of might lead to the third one on the list, which could be insufficient time to sort of invest in going to continuing education courses or finding time to research new literature. Some staff may have been practicing for a while and they have this anecdotal evidence that says that their practice is effective. And you may find that they're resistant to change and they're not interested in sort of adapting their practice to align with new changes in the literature. And other times, individual barriers could be attributed to unclear professional roles or responsibilities. I didn't know that I should be screening this patient for X procedure, so I didn't do it. Okay. When we get to the organizational level, Not all organizations have the availability or the resources to support continued program development, and that may be a challenge. Resources and budgets are certainly different in different settings, which can sometimes be a challenge. Okay, and sometimes there are not policies or procedures in place to sort of assist with this project and maintaining best practice. And then when we go to the broader scale of systematic barriers, we may find challenges with sort of current legislation or regulations limiting change. So just a very broad example, we may find something in the literature that says a patient should receive intensive therapy for 4 weeks, but in acute rehab, we know that patients are sort of being discharged at an earlier time frame than that, generally speaking. Can we sort of make that process work in this setting if we know the time frame is going to be shorter? Okay. So from there, we enter step 4 of the cycle, which is called selecting, tailoring, and implementing interventions. And this is where we're finally at a point that we are looking to overcome those barriers that we've found and facilitate project success. This phase is where we start to disseminate the information to our staff to begin utilizing it. And in the next few slides, I'm going to review some of the interventions we found to be helpful here as we started our program. One of the biggest steps that you need to consider before the RMST program is rolled out is obtaining the necessary equipment for your patient population. When you're thinking about selecting the devices that are most appropriate, we would suggest that you look at the most common diagnoses and goals that you treat on your caseload. In addition to sort of looking at the patient severity and level of debility that you see most often. And this is going to differ significantly across the continuum of rehab. You want to ensure that the trainers you pick will have threshold settings appropriate to your patient needs. From there, think about your anticipated therapy goals. What will you be targeting most often? Are you working with frequent trach weaning and decannulation, targeting oral pharyngeal dysphagia? Are you a physical therapist looking to improve pulmonary endurance for physical activity? This is going to help determine if you will benefit from having inspiratory and or expiratory trainers to achieve those goals. From there, the next challenge is sometimes a budget, okay, and obtaining funding for the devices. You will benefit from sort of reaching out to your local vendors to obtain quotes. Sometimes buying in bulk can help reduce the costs if you anticipate frequent use of the RMST devices in your practice. If you have access to the data, we found it helpful to sort of complete a look back of our patient caseload to approximate the frequency that we thought we would be utilizing RMST in our patients. And then from there, we generated an estimated budget for month, quarter, and an anticipated annual cost for our initial proposal of the project. Our patient population in acute rehab is quite varied. So we opted to obtain low and high threshold trainers for both inspiratory and expiratory therapy. We were able to obtain peak flow meters to use as sort of an outcome measure. Although I will say we were fortunate that these were already on par at the hospital and we were able to obtain them through that budget and that system. And then we were able to obtain a digital manometer for objective measures of MIP and MEP ratings. Digital manometers and peak cough flows peak flow meters are not essential and should not prevent you from continuing your program development if you might be in a setting where you're working within the confines of a tighter budget. And just to add, and Jenny can talk a little bit more about this later in the talk, RMST devices are now sometimes being covered by insurance. So it's worth exploring all the options for what's available to help obtain the devices. Okay, so the next step in the development process was to clearly establish enrollment criteria and our staff workflow so that there were clear expectations and consistency of use across our therapy team. So we developed a policy and procedure outlining the following criteria. One of the biggest at the onset of the project was really selecting our inclusion and exclusion criteria for patient selection. This is key to identifying which patients may benefit from use of RMST, but it also prevents using it in a case where there could be potential for harm. I didn't include our specific criteria here, as I do believe it should vary based on your population that you're treating. But this was an area that we talked to a lot of the experts in the field about, and many of our colleagues in the process. And if anyone is sort of at this phase of development, I'd be happy to talk to you about what we selected and why. From there, we sort of looked at the appropriate time frame for initiation of RMST, and we sort of touched on this before. Did we want to sort of start at the initial onset of acute rehab admission, or did we feel we needed to wait a little bit? And for us, we did not feel that there was a time frame based on our physician recommendations that we needed to wait before safely initiating the modality. We discussed guidelines, whether we needed to obtain an MD order set before starting therapy. Our facility is viewing RMST as another treatment modality that falls under our evaluation and therapy order sets. So we are not obtaining RMST orders for a large number of our patient population. The only exception to this rule is our patients who have tracheostomies. We are obtaining orders before initiating RMST with our trach patients, and then getting a secondary order if the patient is decannulated during the admission before reinstating the RMST treatment once the stoma site is fully healed. From there, we sort of established our treatment protocols for frequency and intensity, which we set up in alignment with what's in the research. We wanted to determine parameters that we were monitoring to ensure tolerance of the treatment. So our setup is that we're assessing pre and post vital signs, including O2 sats, blood pressure, and heart rate. In addition, for monitoring for any subjective observations or patient reports that would be concerning. We also reached out to a lot of the experts in the field at this phase, and one of our biggest questions was whether we needed to have specific cutoff points for heart rate and blood pressure that we would not want to utilize RMST. And after talking to several people and our physicians, we decided that instead we're looking at patient baselines, tolerance of physical activities in PT and OT, and more importantly, sort of watching for any changes in vital signs once we sort of initiate the treatment. And if we have any concerns, we're able to initiate discussion with the medical team prior to starting therapy to sort of get their input in terms of medical clearance before we start. And I will say at this point that I think in the 4 years we've been doing this, we maybe have had 1 or 2 patients that we felt were outside the criteria that we didn't feel comfortable using the measure with, the modality with. Another key area to discuss before starting to use the device includes deciding what your outcome measures will be. You're going to use these to sort of track progress. Selection of these will be based on your intended therapy goals. And a few slides from now, we'll talk more about what we selected here in our program and why. Okay, but these will also sort of help justify the cost of the program if you're needing to go back for reapproval of your budget. And from there, we standardized our documentation procedures. So we made sure all of the key components were being documented in our medical record. And then finally, we ensured our practices aligned with all of the infection control guidelines for patient and staff safety. Okay. So once those steps were set and we felt like we knew how we wanted to roll out the project, we needed to train our teams to increase the knowledge foundation and rationale for use, reviewing our departmental procedures, and providing opportunity for hands-on training. There are fabulous courses available by experts in the RMST world. We sent our RMST champions to in-person trainings, who then use knowledge translation models to share that information with our team. And this process definitely impacted by the timing of our rollout right in the COVID phase. But I will say that these courses are very accessible, are well worth the time and money. And I would highly recommend looking into taking a specific training course in RMST if you're looking to learn more or start utilizing it in your practice. Each staff member then received a personal training device, an EMST device, to practice prior to them using it with our patients. And for consistency of training, we developed an online training module that was a reference point for our staff as questions came up, but we're also using it for onboarding our new team members prior to them receiving their hands-on training. From there, we went back to documentation. We worked to sort of make our documentation as efficient as we could to overcome that big barrier of time that we all feel, that time crunch. We utilize Epic as our EMR, and we initially created a smart phrase for consistency of data points that we wanted to track. And on this slide, we sort of outlined the data points that we've been collecting. Our notes are including documentation of our vital signs, level of O2 supports when indicated, baseline MIP and MEP levels. We're including the normative MIP-MEP values based on the patient age and sex, the type of trainer that we're utilizing, threshold levels that we're using in training, number of trials completed, and then the accuracy level that the patient is reaching the threshold. In addition, we're sort of documenting the level of support and the type of queuing that's needed for successful completion. We've since been able to include these measures, have been able to include these measures into our flow sheet. That has further streamlined the workflow and increased our ease and ability to sort of run reports to analyze our data and outcomes. All right, so we've reached step 5 of the cycle. Once we've implemented intervention and it has been launched, step 5 is monitoring use and application of the new knowledge. This requires defining what we want to measure and how we're going to measure it. We can think of there being 3 types of knowledge that we can monitor for. The first is conceptual knowledge, and this demonstrates a basic understanding of the information. This is often useful to monitor at the onset of a project to ensure that there's a sufficient knowledge base. Examples of this can include knowing the rationale for selecting an RMST as a treatment modality, or understanding what therapy goals we can target with inspiratory versus expiratory training. The next type is instrumental use of the knowledge, and this is monitoring actual changes in behavior and practice, which is the intended goal. Are staff selecting appropriate patients for RMST trials? Are all components of documentation being entered? Are orders being obtained when they're indicated? This phase, we're utilizing a lot of chart audits and or co-treatments to sort of obtain this data and track how consistently these components are being utilized. And additionally, there's strategic use that relates to the manipulation of knowledge to attain specific power or profit goals. And this may be applicable if projects seek to reduce length of stay or risk of infections. We're not directly looking at this with our RMST program, but an example could include looking to see if patients return to PO faster or show improved endurance in PT. And we'll tie this into the next step of the cycle in just a second. Monitoring is key to determining how and to the extent to which the knowledge has diffused through the users. We won't see any changes in our outcomes if the knowledge is not being utilized consistently and appropriately. Okay, we utilize reminders as needed. There's oftentimes emails with percentages of charts meeting compliance, reminders about pieces of information when we're noticing that there are trends missing in documentation, just to provide some of the more common examples. Okay, so we're finally rounding the curve and we've reached step 6, which is evaluating our outcomes. Once the practice has been integrated and the knowledge is being used as intended, the next phase is to evaluate the outcomes of the knowledge translation. Are we seeing the intended change to support continued use of this knowledge? Are primary and secondary outcome measures changing, and are we seeing associated changes in function? If not, we might need to circle back to find out why. So just to include some added tips for outcome measures, not meeting an intended outcome does not mean that the project was not worth it. The initial steps, if we're not meeting our goals, would be to make sure that your outcome measures and goals are accurately assessing the project that you're hoping for, the progress you're hoping for. This is not always easy to quantify or to measure in a way that is obvious. Were there maybe unexpected benefits you can show gains in that you weren't expecting at the onset of the project? RMST was used as a tool to strengthen our respiratory muscles, but we found all these secondary outcomes that are now being used to treat speech and physical therapy goals. Even recently, it's being evaluated to see if it can support pelvic floor rehab. So always remaining attentive to the changes that you're seeing, as very often there are changes in function that we can document to show progress. It's also important to set a realistic time frame for measuring targets, as it takes time for practice to change and achieve consistency. We've seen a significant change in how RMST is being integrated into our treatments here at NYU since our initial program rollout. It's now being started earlier in the rehab stay. It's being used more consistently for appropriate therapy goals. And therapists are starting to integrate it and think outside the box for other ways that our patients could benefit from use. Okay, so if we had monitored our data only in those initial 3 to 4 months after rollout versus looking at it now a little bit later after the program has been up and running, we would find very different results. So just thinking about the time frame that's appropriate to sort of go back and analyze your data and your outcomes. I want to spend a couple minutes just reviewing the outcome measures that we selected here in case it's helpful to anyone at this phase as you're deciding what to track. MIP and MEP are mandatory data points for all of us as our primary measures here, regardless of the treatment goal that we're targeting. We're obtaining these through our digital manometer, but they can certainly be approximated via the trainers, okay, if you're not able to get the digital manometer. We were initially assessing peak cough flow only when cough strength and secretion clearance were therapy goals, but we're now using it as a regular outcome measure because it's in alignment with research supporting a correlation to presence of oral pharyngeal dysphagia and identification of impaired airway protection and clearance. Okay, so these three are sort of becoming our mandatory points. We gather them on initial evaluation to determine candidacy for RMST, weekly reevaluations, and at discharge from our unit. And then our training thresholds are recalibrated weekly following reevaluation as patients' MIP and MEP improve. We then sort of have our secondary outcome measures where we're looking to document changes in function. Since we were utilizing we are using RMST most frequently for treatment of oral pharyngeal dysphagia in our setting. Our secondary outcomes primarily revolve around swallowing measures. They include monitoring the recommended safe diet consistencies, our functional oral intake scale levels, NOMS levels, and then the penetration aspiration scale when objective imaging is indicated. And I will say that our patients are receiving objective imaging before initiating RMST when the primary goal is oral pharyngeal dysphagia. But due to changes in length of stay or sometimes unexpected discharges, we're not always to sort of able to, to obtain these measures at the final data point before discharge. NOMS ratings can also be taken and used as a functional outcome measure for speech and/or voice, if those are a primary goal. And just in case there's any physical therapists on the call, I wanted to sort of review what our PT team here has been using. They're using they're using RMST to target respiratory efficiency, lower perception of dyspnea, optimizing blood flow distributions, improving exercise tolerance, and cough function for secretion clearance. And right now, they are using MIP and MEP as their primary outcomes. And then their functional secondary outcomes are things such as the function in sitting test or the FIST, and evaluations of static and dynamic sitting balance. Okay, so these secondary outcome measures may vary based on what your goals are that you are treating. Okay, and will be important to look at before project rollout. So when we went back and sort of reviewed our program, okay, we definitely focused at the onset of the project, given the medical complexities of our patient population. The fact that we had slight deviations adapting the literature for our population, and then wanting to show the impact of the program to help justify the cost and our budget. We developed a very simple tracking system in Excel to be able to retrospectively analyze our patient data. Most importantly, we wanted to ensure patient safety, looking for any unexpected complications, needing to terminate therapy and/or significant changes in O2 needs. And again, I think we've had 2 patients that we sort of terminated therapy for in all the years. Secondly, we wanted to look back at the KT cycle and evaluate our program development. Were the trainers we selected meeting our patient needs? And we did actually change the devices that we were ordering after reviewing the numbers that we were dispensing, and found that devices with a wider training threshold helped to sort of accommodate for patient progress without having to dispense a secondary device. We wanted to know if our treatment protocol was achievable in the acute neuro rehab setting. Could we follow the 5-5-5 protocol, training at 75 to 80%? And the answer for the most part has been yes, with the exception of sort of the COVID-19 population. We did sort of adjust the training thresholds at that phase, but we have found that even in the context of the cognitive linguistic challenges our patients face in this setting, the RMST program has been very effective, and the majority of our patients are able to use it. Lastly, we wanted to track secondary outcome measures to determine if we felt the intervention was supporting our intended outcomes. So trends in our data are definitely indicative of a benefit of RMST implementation. We have a high frequency of decannulation, decreased suctioning and O2 needs, and advances in safe diet textures. But I want to make it very clear that we have not utilized a comparative group, okay, and we are not doing a formalized research study on the outcomes. So we cannot definitively speak to the results in the setting. But subjectively, we do feel like we've had substantial benefit since we introduced the program. Okay, and we've reached the last step of the cycle. Step 7 is sustaining knowledge use. The last phase of the cycle is determining if the knowledge continues to be used after the structure of the KT process is removed. Project sustainability has been identified as one of the largest challenges in the KT process. It's been shown repeatedly in the literature, including studies by Proctor et al., that less than 50% of projects sustain practices of high fidelity. But our patients deserve continued use of these effective treatments. And this is critical for continued integration of the knowledge over time. So we need to monitor it closely. We've found that projects that staff see the value in tend to achieve higher compliance rates and have continued growth, much like our RMST program since it was rolled out. We continue with the use of our online modules, chart audits, clinical case discussions for new staff, as well as sort of clinical case discussions of any unique cases where we've been utilizing the RMST modality, okay? But here we have achieved a pretty high success rate even after the structure of the KT process was removed. I want to take a couple minutes before we finish up to thank you all for joining tonight, first and foremost. I also want to thank my program manager, Liat Rabinowitz, and my other colleagues at NYU who I worked with in conjunction to develop our NYU RMST program. They supported the initiative from the onset, and this program would not be where it is today without them. I'd also like to thank the incredible members of the NYU Clinical Specialist team who are listed here. This team worked together over the last year to help create the standardized process for knowledge translation, okay, which we have talked through here tonight. And then in summary, delivering evidence-based care requires continuous integration of the latest research findings into clinical practice. The knowledge to action cycle offers a structured approach for effectively developing, implementing, and sustaining new clinical practices. RMST has been proven to be effective across diverse patient populations, but requires planning and identification of barriers to support successful program development. Development of procedures need to be individualized to your institution and patient population to be the most effective. And finally, monitoring of a new program is essential to ensure adequate dissemination and use of the knowledge. This slide includes some additional references on knowledge translation if anyone is interested in learning more. I've included my contact information, and here's my email if anyone has questions after we conclude tonight. And finally, thank you again to Aspire for the opportunity to speak tonight. I hope the information presented can be helpful to those of you listening at any phase of your RMST development, and encouraging you to consider use of the KT cycle to help organize your ideas at the onset of any program development. We're so grateful for the support that we received from Aspire and other experts in the field during our journey setting up the RMST program, and we'd be happy to answer any questions as you walk through your process. I'm going to turn this back over to Jenny, and I believe we're going to open up the forum for any questions now.
Colleen, thank you so much. I think this is so helpful. I think a lot of times we have an idea and we are not quite sure how to make it a reality. And this is a very nice structured framework. A lot of people are going to their administrations and proposing an RMST program, but being able to go to your administration and have all of this behind it certainly sets you up for success. So we are opening the floor up to questions now, and we definitely have a few coming in. We had one regarding the role of PTs in developing an RMST program. And I just want to preface by saying that a lot of times disciplines are not aware that this is a very interdisciplinary intervention, right? I had a PT expert once say to me, how come speech therapists love EMST so much? And I said, oh, because of the evidence, right? But a lot of times we're not aware that this is a fantastic opportunity for you to work together. And can you just touch on how, if it was helpful to you in developing your program, having that kind of interdisciplinary support?
Absolutely. So I think it was really useful to us to sort of look at the literature on both sides. And the literature on the speech and physical therapy side do sort of line up in terms of frequency and intensity, which was sort of support what we were doing. Our disciplines found that there was the greatest overlap sort of working in our spinal cord population. So we tried to sort of figure out protocols for who was going to do initial assessment, how we were going to divide and treat these patients that were overlapping on our caseloads. And I think the opportunity to sort of look at, have the information from the physical therapy side, particularly in terms of restrictions, right? When is it safe to sort of initiate treatment after someone has had a pneumothorax or, rib fractures? Their literature definitely sort of was helpful to us in our practice. As we don't, we're not as familiar with that, and it was helpful to sort of get that impact along the way. So definitely, there's currently ongoing conversations. We're analyzing the data from both sides on a regular basis and always looking to see if we can expand use in our patient population.
Yeah, I think that's wonderful. And I think it's really nice to have such a whole person kind of approach, right? Rather than kind of just staying in our lane and targeting one thing, where we can do something that is helping the person as a whole and it's really patient-centered. I think it just sets the patient up for success too. Another question we had was, how successful have the patients been in continuing RMST in the home health setting? So I'm not sure if you're going to be aware of how your patients are continuing, but I will say from experience from the home health therapists that we work with, and as well as the telehealth therapists, they love this device because it's a tangible thing. You can set it and you can train a caregiver. And the caregivers are really big advocates for the patients who can't advocate for themselves to kind of continue this therapy from a very acute phase onto home health and beyond.
I think that's a great response. We are not able, unfortunately, to track it that thoroughly into the home setting. We did develop patient education handouts, and at discharge, we are giving patients sort of the thresholds that we've been training at and making recommendations for sort of how they should continue with their home therapists. So I agree fully. In the beginning, we were getting some phone calls from the local home therapists who were interested in learning more, which is a great way to collaborate and sort of expand the device use after they were transitioning to the next settings.
Yeah, and ensure the continuity of care, which is really nice, I think, for the patient too, when they're familiar with something and can see and track their progress. Another question we have, well, a few people have asked if the slides are going to be available. So this will be recorded and available on demand on our website in a few days. So you can check back with us, and you are absolutely welcome to refer back to these slides. Somebody asked if you could share the slide with the bibliography again, if you don't mind, the references.
Happy to.
Okay. And people are asking what your documentation looks like. I know you said you're in Epic. Do you guys use like a flow sheet or
So at the onset, we did have a smart phrase that we were sort of entering our data into. At this point, it has transitioned over and we have all the data points in our flow sheet and it pulls into our note when we're utilizing our MST. And it has made it much more efficient, but it took a little bit to sort of get the programming set for that. But it has been a nice upgrade. But if anyone's interested, I'd be happy to sort of share the smart phrase that we were using just as a general model.
Yeah, that's great. Thank you, Colleen. And Colleen did share her email, which is at the end of the slides, which maybe we could go back to when we're done with this one. A lot of people are very, very appreciative of you being here and sharing this information today. Let's see, we have another question that says, we are wondering approximately how many patients you treat with RMST protocol.
That's a great question. I will say it definitely fluctuates. And I would estimate that we're probably somewhere in the ballpark between 10 and 15 patients a month. Our primary outcome measure is definitely oropharyngeal dysphagia. And then probably secondary behind that would be decannulation and trach weaning. But I do think we're integrating it very regularly at this point with our caseload, and my guess would be somewhere between 10 and 15 a month.
Great, thank you. Somebody asked about insurance coverage of devices, so I'll take that one. The EMST 75 is covered by Medicare and some other insurances. It is considered a DME. The EMST 150 is not, because this device goes to higher thresholds and it is used by singers, athletes, etc. So it is used in the absence of illness. For insurance coverage, there are forms on our website. You need a script, just like you would for any DME, and to fill out the forms, and that gets sent over and processed through us. However, at the acute care level, very often, depending on how your reimbursement works, if it's like bundle reimbursement, and you can talk to your administration about this, it is something that facilities will often have to purchase for their patients because that insurance coverage may not apply to the population. So I will say it's different by facility. We do have an insurance specialist. You can always reach out to me. My email is jenny@emst150.com, JENNY@emst150.com. I'd be happy to help you as much as I can. And somebody else also asked, which courses for hands-on training do you recommend? Do you have recommendations?
I think I would say at the onset, I did sort of take several and I found them all to have different benefits. Aspire certainly offers courses and there are several others. I don't know. I don't know sort of.
I know Brooke
Brooke Richardson.
Brooke Richardson has a course that is pretty comprehensive. And there are a few others. But I agree with Colleen, if there is no certification required to provide RMST. However, you do want to have a very good understanding, because despite there being a general protocol, there are often patients where you may need to adapt that protocol. As you mentioned with your COVID-19 patients, for me, I work with trach and vent patients, and they're really not getting to 75% of their MEP or MIP for our training. So you do want to have a good kind of background knowledge of the clinical applications of this intervention. And let's see, there was another question that says, oh, You're asking if you're providing certificates of attendance. You can also email me, Jenny at emst150.com for a certificate of attendance for today's webinar. That way you could use it towards your professional development hours. And somebody asked, do you recommend IMST while using RMST for clients? Do you often use IMST as a speech therapist?
I would say at the onset of the program, we were not using it very often. I do think we are using it a little bit more frequently in our practice. It is probably an area we can continue to expand on, if I'm being honest. I would say 80% of the patients, 80 to 90% we're using expiratory training. We are using inspiratory for some of our tracheostomy patients to work towards decannulation, improving cough strength. But it is definitely utilized less frequently. And my estimate would be that we're utilizing it probably 10 to 20% of our patients. But Jenny, I think you might be able to sort of speak a little bit better to that than sort of looking at a wider range of patient population than we may have.
I'm putting my email in the chat for anybody who wants to reach out to me. Feel free. And so IMST, first of all, I'm going to say that it is a little bit more popular with physical therapists in their realm. It started to be studied a little bit. The research came out a little bit, maybe 20 years, started to be studied before EMST. So there's a wide body of research. EMST is very popular with the speech therapist because specifically the research shows and supports its use for swallow rehabilitation, for dysphagia rehabilitation. There's a really good podcast episode on Swallow the Gap regarding IMST and the applications as you may want to use it for as a speech therapist. You can also email me for the link to that because I don't have it handy, but it is on our social media. So if you follow us on Instagram at Aspire Respiratory Products or on LinkedIn at Aspire Respiratory, that information is posted up there and you'll be able to find it there as well. Okay, and let's see, a couple more. Can you share data regarding patients with severe dysphagia in acute care and how this avoided PEG placement? So I don't know if there are any studies that look specifically at patients avoiding PEG placement, but if you go on our website, there are research lists and case studies, and they're separated by population. So if you take a look under swallow or dysphagia, you can find the research there regarding the intervention and how it can improve swallow function. And then, is it true Kaiser doesn't support RMST devices because the evidence isn't there yet? I'm not aware of that. I don't know. But the evidence we have, I would say, considering that EMST came about in the 90s, is pretty vast. Like it's a pretty vast body of evidence. And also compared to other interventions, specifically for swallow, as Colleen mentioned, a lot of people would consider it a gold standard. Okay. And we have time for one more. It says, is the IMST a different device? I've seen the Philips PEP threshold device is one device and you switch the mouthpiece for IMST versus EMST. Okay, so with the Aspire devices, we have two EMST trainers. The difference is the pressure threshold ranges. The EMST 75 goes from 0 to 75, and the EMST 150 starts at about 30 and goes to 150. Either one of those is compatible with our inspiratory muscle adapter, which is an adapter that you place right onto the device. And when you put the adapter onto the device, you get the pressure on the inhale. So when you're doing IMST, you're targeting your diaphragm and your intercostals directly. Okay, so thank you very much, Colleen. Again, we really appreciate this information. This was super informative. We will be having another webinar. I'd like to invite everybody to come back. Thank you for being here. December 11th, we have Ed Weiss presenting a talk entitled Aspiration, Pneumonia, and Diets, Protecting Your License from the Big Three. So any SLPs in the audience, that one will be a good one too. And we look forward to seeing you there. Thank you again, Colleen. Have a good evening, everybody.
Good night, everyone.
Good night.